So good afternoon, everyone. Like mentioned, my name is Katessa Howard. I'm one of our infectious diseases clinical pharmacists here at WU Medicine. I practice up at Ruby. And today we'll be talking about monoclonal antibody therapy and oral antivirals for the treatment of COVID-19. So really focusing on outpatient treatment for COVID-19 today. A few objectives for what we're going to talk through today is just reviewing therapies overall for the treatment of COVID, and then specifically discussing the role of the anti-SARS-CoV-2 antibody therapies or monoclonal antibodies and the oral antiviral therapies, and going through some key differences and points about these as we now have a much larger armamentarium for our outpatient treatment for COVID. So first, I just want to talk about all of the treatments in general that we have for COVID-19. So compared to March of 2020, we have really grown in our tool belt of the therapies that we do have available. One thing that stays consistent throughout this is supportive care, which we're not going to be talking about today, but something important to remember for all of our patients with COVID-19. Then moving into the anti-SARS-CoV-2 monoclonal antibodies or the mAb therapies, antivirals, which we started with just one IV antiviral remdesivir, and now we have an IV and two orals, which we'll talk much more about later. And then going into our steroids and immunomodulators, so things like tocilizumab and our Janus kinase inhibitors like baricitinib. Now, these are both used in the inpatient setting, but important to just remember that those are treatment options overall for COVID-19. But once again, focusing just today on the mAbs and the oral antivirals. So understanding why mAbs and oral antivirals are such key players for the treatment of COVID-19, particularly in the outpatient setting, I think it's important to look at just treatment across COVID-19 disease continuum. So if we look here, this is just a graph of a severe COVID infection. So it goes on the timeline, which are these two bars on the top and bottom, and it goes from day of infection, which is normally -5, to day of symptom onset, which is typically day 0, out to day 20. And you can see here, there's different phases of this disease. From the time of infection to symptom onset, that's really when we're in this incubation period where the virus is ramping up and replicating right before we get those symptoms. Then we move into more of the viral disease portion of COVID-19, which are these days 0 through about 10. And then day 10 is really where things shift with severe COVID. And that's when we a lot of times see our patients admitted to our intensive care units with more of that hyperinflammatory phase. So for our outpatient treatments and for our monoclonal antibodies and oral antivirals, we're really going to be focusing on this virus shedding portion of COVID and days from symptom onset, because we're trying to target it early in the disease phase when the virus is still replicating and ramping up. So these are where our monoclonal antibodies fall into place and our antivirals. Even our IV antiviral remdesivir falls into this category for our inpatient admissions as well. So this is where we can think about the outpatient setting, trying to catch these patients in this viral portion of their infections to hopefully prevent a hospitalization in those at super high risk for progression to severe disease by using one of these therapies. And then just remembering that we do have our steroids and immunomodulators more for that inpatient setting once the disease has taken more of a hyperinflammatory phase, and that's when our more complications come in. So when we think about the timeline of outpatient COVID therapies, our first monoclonal antibody did come out in November of 2020, which honestly kind of feels like a lifetime ago in COVID terms. It feels like forever ago. But between November 2020 and December of 2021, we did have more monoclonal antibodies therapies developed. So we went from having just the bamlanivimab to having our REGEN-COV, which is often referred to as Regeneron, which is the casirivimab and devimab product. We went to have a combination therapy with bamlanivimab, etesivimab, and then most recently sotrovimab. We were really focused on our vaccine efforts during this period too. But then it seemed like right before Christmas, we had two brand new oral antivirals that came into play and received those emergency use authorizations in December 22nd and December 23rd, respectively. So a lot has happened just within the past month in terms of how we can treat our outpatients with COVID-19. I do just want to spend a brief moment to talk about the National Institutes of Health, or NIH, non-hospitalized patient treatment guidelines, as this really sets the stage for when we're going to use what therapy and the benefit of the therapy. So when we think about who qualifies for these treatments, we have to think about those non-hospitalized patients with mild to moderate COVID-19. So they've had laboratory confirmed COVID, either with a PCR or rapid antigen test. And then they have to be deemed high risk for progression to severe disease. So the high risk for progression to severe disease is a very long list. And this list is provided by the CDC, and this is referenced on the NIH website and then on the in the individual emergency use authorization packets for each of the therapies we're going to talk about today. So there's a long list of what can qualify for high risk for progression to severe disease. So I always just turn to that list when I'm trying to see if a patient will qualify for a therapy or not. And then this is the NIH prioritization of what they recommend for outpatient treatment. So as you can see here, Paxlovid, which is nirmatrelvir, and ritonavir, which is one of our oral antivirals, they recommend upfront. So they give that a grade of an A2A recommendation. If Paxlovid can't be used, and we'll go through some instances where it can't be used later in the presentation, or if it's not available, as all of these therapies are in very short supply, as many of you are probably aware of as well already, then they recommend our monoclonal antibody that is currently available, sotrovimab, which is, I'm going to focus just on sotrovimab for this presentation, as it is the monoclonal antibody therapy that retains activity to the highly circulating Omicron variant. So the NIH gives both of those the same grade of recommendation. If neither of those therapies can be used, they do recommend remdesivir, which once again is still just IV, but can be used in the outpatient setting now. A little bit out of the scope of what we're going to talk about today, but I wanted to include it just for completeness sake, and happy to take questions on that at the end after the didactic portion of the presentation is finished. It's a little bit lower of a grade of recommendation, but the NIH still recommends it. Then if absolutely the other three, Paxlovid, sotrovimab, or remdesivir cannot be used, the NIH recommends then our other oral antiviral, molnupiravir. And we'll go into why this is really this last line recommendation in just a few slides. So the when and why of when to give these therapies, we really want to give them as soon as possible after symptom onset. And then the NIH recommends these therapies in this order, in that particular cascading order, due to the clinical efficacy that has been seen in trials to date, the availability of the products, the feasibility of administering those IV products such as sotrovimab and remdesivir, potential for drug interactions with Paxlovid. So Paxlovid contains ritonavir, which is, as a pharmacist, every time I see that drug, I get a little queasy because there's always going to be a drug interaction that we have to think about and work through, but definitely can rely on your pharmacist for that to help with. And then also the regional prevalence of the Omicron variant. So all of the therapies that I just showed in the previous slide retain activity to the Omicron variant. And once again, the role of these therapies is really to prevent hospitalization and progression to severe disease in our highest risk patients. So we're limiting use in these emergency use authorization stages to those patients, really because our supply is so short, and we're wanting to make sure that the patients that can benefit from these therapies the most will receive them. So I want to talk a little bit about the COVID-19 oral antivirals. So we have Paxlovid, like we've mentioned, which is the nirmatrelvir and the ritonavir, and then molnupiravir, which is our other oral antiviral. So I'm going to start with Paxlovid first, just to briefly talk about how it works. So it is a protease inhibitor, so it stops viral replication. So as you can see here in the picture on the side, after the SARS-CoV-2 virus gets into our cells, the Paxlovid, the nirmatrelvir component, goes down here to step 3 and prevents these viral proteins from being formed. Thus, it stops viral replication. Ritonavir doesn't have any activity against SARS-CoV-2 or COVID-19. It just acts as a booster for the nirmatrelvir, and it gets the concentrations at a level that's needed to be active against the virus. So the ritonavir component is much like the ritonavir component that we use in our HIV regimens, just boosting up that main protease inhibitor, but also creating problems with drug interactions. When Paxlovid was granted an emergency use authorization in the middle of December, it was authorized for use in treatment of mild to moderate COVID-19. So they have to have that confirmed COVID test. It's authorized for adults and pediatrics. So peds patients have to at least be 12 years of age and be 40 kilos or greater. So that's just something to keep in mind. They have to have that high risk for progression to severe disease and within 5 days of symptom onset. So when we think to that original graph I showed of when the virus is really replicating, it's really within those first few days after symptom onset. So for this to be super effective, we want to use it while that virus is replicating to stop further viral replication. It is not authorized for hospitalized patients. One thing to keep in mind is you do have a patient that has started on this in the outpatient setting and subsequently does get hospitalized, they can complete their 5-day course of therapy per the EUA. But if they're already hospitalized, it cannot be started in the hospital setting. It's not for pre or post-exposure prophylaxis, and it can't be used for longer than 5 days. Major contraindications are, of course, hypersensitivity and then major drug-drug interactions. So I wanted to go through a couple key points. So the dosing for Paxlovid, we do have to take into consideration renal and hepatic function for our patients. So patients with normal renal function, they'll get 300 milligrams of nirmatrelvir, which are 2 tablets twice a day, plus 100 milligrams of ritonavir, which is 1 twice a day for 5 days. Then if they do have a renal impairment with a eGFR of 30 to 60, that dose does need to be reduced. So that would just be that reduced dose of the nirmatrelvir in that case. And then it's not recommended if patients have severe renal impairment, so an eGFR less than 30 or severe hepatic impairment with that Child-Pugh class C. So I just wanted to show a picture of what Paxlovid looks like. It comes in these blister packs, and that's how it's supplied to the pharmacy. As you can see here, it's labeled morning dose on the left side and evening dose on the right side. So it says on here, take 3 tablets at the same time, which is going to be 2 of the nirmatrelvirs and 1 of the ritonavirs. But if the patient has renal dysfunction, the pharmacist is to pop out 1 pill on each side of the nirmatrelvir to give that 150 milligrams for each dose, and then there's a sticker placed on top of that. So it might just be important to counsel patients on it. They might see this sticker and they might look like a pill has been popped out of their blister pack, but that is supposed to happen, and just to make them aware of that renal dose adjustment if we do have to adjust for that. But there are a lot of drug interactions with Paxlovid, so it's a must to perform drug interactions. So one thing I always like to tell our providers when I'm getting asked this question is, there's been about 16 pharmacies in West Virginia that have been allocated Paxlovid and molnupiravir, most of them being Walgreens. There's some Bruce pharmacies, and I'm not sure of the names of all the rest, but I'll show how to get to those in a minute. But we have to keep in mind not all of our patients utilize those pharmacies every day, so they may not have a full list of their medications when filling this, so we can't rely on that last drug interaction step. So it's really important at the prescribing end to make sure we perform a drug interaction screen prior to prescribing. One drug interaction screener that I love is Liverpool. This is from the University of Liverpool, and it's a great drug interaction checker. The NIH actually references it, and there's a link at the bottom of the page on how to get to it. So you would go in here and put in Paxlovid and then what other medication they're on. Examples of interactions with ritonavir, I could have a few slides on that, so I just included a few of the most important drug interactions to keep in mind, but I always recommend to put every concomitant drug the patient's on in the drug interaction checker. So for instance, let's say your patient is on rosuvastatin and you're wanting to prescribe Paxlovid. If you put that in into Liverpool, this is what the interaction will look like, and it'll show you if it's a potential interaction, the summary and description, and what the recommendation is. So I do find it to be really comprehensive, and I think it gives a lot of great information, a little bit more than our traditional drug interaction checkers that we use. Switching gears a little bit to molnupiravir. So this antiviral works very different than Paxlovid. It actually is a riboside analog that inhibits viral replication. And it works by this mechanism known as a viral error catastrophe. So down here in step 4, it actually incorporates itself into the viral RNA. It creates errors in the viral genome, and then it subsequently inhibits viral replication. So it's a very complicated, complex type of mechanism of action, but it does work a little bit later down in the into the viral progression and at the NRA replication step. So the molnupiravir emergency use authorization came out one day later than Paxlovid, and it was authorized for use in patients with mild to moderate COVID, once again confirmed via the test. And it's only authorized for adults, so only those 18 years of age and greater, and we'll talk about why that is in a moment. And then it's once again only for our high risk to progression to severe disease per the EUA and within that 5 days of symptom onset, just like Paxlovid, as we're wanting to hit that viral replication phase. The EUA does state that molnupiravir really should only be used when alternative COVID-19 treatment options are not accessible or clinically appropriate. So much in line with that NIH schema that I showed a couple of slides back, really our last line therapy. It's not authorized for hospitalized patients, once again, if they're started on an outpatient that can continue at inpatient, not for pre or post-exposure prophylaxis, and use is only for 5 days. So its dosing is 800 milligrams twice a day for 5 days. There's no need for hepatic or renal impairment adjustments at this time. But the key points and the warnings with this agent are ones I really want to focus on for just a few moments. There is embryo fetal toxicity risk in which patients must be counseled on with molnupiravir. It's not to be used in pregnant or lactating individuals, and pregnancy really should be ruled out prior to prescribing in any woman of a childbearing potential, just because there is this risk of embryo fetal toxicity. So we just want to make sure that the patient would not have any chance of being pregnant. If it is given to a female must use a reliable method of contraception for the duration of treatment and 4 days after the last dose of molnupiravir. And males should use a reliable form of contraception consistently during treatment up to 3 months after the last dose. We really don't have a lot of data at this time after that 3-month period. There's ongoing studies still going on and how long this embryo fetal toxicity may be present. But these are just really important counseling points for our patients, just so they do know this. So there's that risk that really kind of puts it, a much lower in the treatment algorithm for our outpatient patients with COVID. And then there's also bone and cartilage toxicity. So that's why for developing bones. So in our patients less than 18-year-olds, that's why it's not authorized for use in those patients due to that concern. So once again, a little not as benign of an agent as some of our other therapies, and really some key warnings to point out. I want to just quickly compare both of the oral antivirals as well. So when we're looking at Paxlovid versus molnupiravir, there are a lot of pills to take a day. So this is just something to keep in mind for the patient that can be very heavy pill burden. There's 6 pills per day for Paxlovid and 8 for molnupiravir. Now, granted, this is a short treatment course of only 5 days, but just something to keep in mind. They do need renal and hepatic adjustments just for Paxlovid. Ton of drug interactions with Paxlovid, none to report for molnupiravir. The side effects, the one for Paxlovid is they may get a weird taste in their mouth, so that's one thing to counsel on. But the biggest thing with molnupiravir would be that reproductive toxicity. Pregnancy, we can't use molnupiravir in pregnant patients. And really the biggest difference too, which also in addition to the potential harms for molnupiravir, the efficacy in preventing hospitalization and death when in patients and high-risk patients is markedly different between Paxlovid and molnupiravir. There was an 88% reduction for progression to hospitalization and death in those that got Paxlovid versus placebo, translating into needing to treat 18 patients to prevent 1 hospitalization, versus molnupiravir only saw a 30% reduction. So that number needed to treat is much higher of 35, which led to that lower grade of recommendation from the NIH, and also translated into the EUA for molnupiravir, stating if no other therapy is available. So this is just where to find oral antiviral therapies. So there are 2 websites. There's a DHHS therapeutics locator, which you can click on that link and it shows a map of where these therapies can be found. And there's also a spreadsheet of available therapies on the second link. I will say this, I'm not exactly sure when this is updated or how often it's updated, but there will list like where you can find. So the Walgreens on this street has 4 courses of Paxlovid. You could find that there. So those are available. You must include a positive COVID test result and date of the test with the prescription, and a do not fill after date as well for the pharmacist to check. So moving into our anti-SARS-CoV-2 mAbs, I'm only going to focus on sotrovimab, as our variants of concern wiped out bamlanivimab right back in April of 2021, and then most recently Omicron is limiting the use of bamlanivimab, etesevimab, and casirivimab and devimab, really leaving sotrovimab for our therapy, our mAb therapy of choice, as the Omicron prevalence does increase throughout the country and throughout our area as well. So just quickly, the mechanism of action. So we talked about the antivirals preventing viral replication. What the mAbs do is prevent viral entry into our cells. So you can see here, here's a SARS-CoV-2 particle. They like to bind to the ACE2 receptor to enter into our cells. However, when we give COVID monoclonal antibody therapy, it neutralizes that SARS-CoV-2 virus and does not allow entry into the cell. So really, it works up here in this top portion of the viral replication process, and it prevents this attachment and entry. So sotrovimab was granted an EUA back in May, I believe, of 2021, and it is authorized for the use of in treatment of mild to moderate COVID-19. Once again, this is another tool in the tool belt for pediatrics, so that you can use it in those 12 years of age and up, as long as they weigh 40 kilos. And they have to, once again, be high risk for progression to severe disease. However, now we have a longer timeline to use the monoclonal antibodies. We can use those within 10 days of symptom onset. So we do expand our window out from 5 days to 10 days in this therapy. Once again, though, early in the disease process, not authorized for inpatients or those requiring oxygen or an increase in oxygen baseline due to COVID. Key points, so sotrovimab, it's a one-time infusion. It's only available via IV now. There are studies ongoing for intramuscular injections, but as of right now, only IV. No dose adjustments needed, and patients must be monitored for 1 hour post-infusion. And the most common side effects are really those infusion-related reactions, with the rare anaphylaxis reported. So when we think about developing criteria for use, we really have to comply with the emergency use authorizations. Important to include those caveats, exclusions, and based on drug interactions, renal impairment, pregnancy status, and et cetera. But really, I do recommend developing an institutional algorithm to guide therapy and to help standardize practice. One I think is super great is just to follow really the proposed NIH algorithm, and then just make a stepwise fashion. If Paxlovid's not available or you can't use it, Sotrovimab if it's not feasible. We didn't talk about IV remdesivir, but once again, that could be an option. And then if none are available, really then pointing to molnupiravir. And then once again, these therapies are so low in supply. Sometimes we're having just a few doses of maybe Sotrovimab, maybe the local pharmacy only has 4 to 5 Paxlovid courses. It's really important to help prioritize when and who can get these therapies and who's at the most benefit. I keep referencing the NIH, but they have a lot of great resources. This is a patient prioritization tiered approach for outpatient therapies, with tier 1 being the highest risk individuals. So those being our immunocompromised patients and unvaccinated individuals as well. So this is just a big comparison table for all the therapies I mentioned today. I did include IV remdesivir just for completeness sake, even though we didn't talk about it. Once again, I really just want to kind of focus on this efficacy of preventing hospitalization and death, with Paxlovid, remdesivir, and Sotrovimab really showing equal results pretty much, with similar numbers needed to treat, and ultimately molnupiravir really showing that not as a robust response. So in summary, COVID-19 treatments continue to be a rapidly evolving process. We have had a recent increase in our therapies, however, they are in short supply, which really shows us that we have to prioritize who is at most benefit for the therapies we do have available. We didn't talk about prevention, but the best treatment does remain prevention, so encouraging our patients to get vaccinated and get boosted when able. So with that, I will take any questions anyone has and open it up for discussion.
Thank you so much, Contessa. That was wonderful. And as usual, I'll be sending out the PowerPoint and all those resources that were included in there in the recap email for everyone to have a copy of. So thank you so much. Dr. Costello, I'm so happy you're on. I noticed you were chatting wonderful resources in there as well. So I'll let you unmute and maybe touch upon those things.
Yeah, thanks so much, Mitra, and great presentation. Sorry, I don't have the video on today. Hopefully you all can hear me, but I would just say, and I mean, if you look at the EUA, molnupiravir technically does not have any contraindications. So I certainly agree. I would also probably not use it in a pregnant patient. In full disclosure, being a pregnant person, I would not choose it for myself, but I think we can't technically call it a contraindication because it's a warning, and it's very clearly stated on the EUA that there are no contraindications. I certainly agree. I think I would use it as last line, but I think that I just didn't know if you wanted to comment on that, because technically I dropped the EUA into the chat for molnupiravir because there was a lot of media reports that that was going to be a contraindication, but the technical EUA doesn't list it as such. So again, I'm not advocating for use in that population, but I think I just, technically the EUA doesn't list it as such.
Yeah, thank you so much, Dr. Costello. I think was just like you, erring on the side of caution. And I think I've just kind of thought of it myself as a contraindication. So thank you for pointing that out. But yeah, per the EUA, it is a warning. But just like you, I would be hesitant to use in that patient population. But I appreciate
absolutely
you bringing that up. Thank you.
Yeah, I think it's just, you know, and then the only thing that I want to share with the group as well, and I can certainly share this with you, Mitra, there was a health alert that was sent out. The resources that Contessa shared were great in regards to finding access in West Virginia. There are 14 locations that have Paxlovid. That's from the state supply, which we're looking at further expanding that as potential supply increases from the federal government. This is a federally allocated drug. So unlike remdesivir, which is now an approved product that is based upon individual systems or hospitals purchasing the drug and having that available, just like other drugs that they would offer. When it comes to the oral antivirals for SARS-CoV-2, I can certainly share that with you, Mitra, and it has the locations in West Virginia, the 14 locations. And as Contessa said, you need to call that location ahead of time to make sure that they have it. We have had courses prescribed. There's sometimes that the course gets prescribed and the provider goes through all the steps and the patient doesn't go pick up the med. And so the state is looking at potentially putting it in additional locations as our supply allocation potentially could increase. But I think it's really important to emphasize that these are extremely limited. And I really appreciate Contessa going over like who should we be selecting these therapies for, because the state only gets a few hundred doses every 2 weeks. And, you know, if you've been following our case count, you know, we have thousands of positive patients a day. So clearly there's not enough therapies to, you know, go around. So that selection is really important, but I'll share those resources. It was in a health alert that had those locations. We also, as the state, developed a checklist to try to help providers go through those different processes, because as I think this was a great presentation, there's a lot of contraindications with Paxlovid from a medication standpoint. And so, you know, not that everybody has leisure time to read 33 pages of a EUA for Paxlovid and, you know, more than 24 molnupiravir, but it's designed to try to help in that clinical decision making if they would qualify for oral antiviral. But that's just what I wanted to add in regards to, in addition to the links that were shared, specific locations in West Virginia that have the oral antivirals.
Thank you, Dr. Costello. Contessa, was there something you wanted to add as well?
No, I was just going to say thank you to Dr. Costello too. I appreciate you sharing those resources and all you're doing, state. Really appreciate it.
Absolutely. And any resources you want to send my way, I'll make sure to have those in the recap as well, along with the two that you sent Dr. Costello in the chat. So we did get a couple questions in, so I'll go ahead and ask those out loud. Dr. Baltiera, thank you for adding that. European Science Agency has it as a contraindication. And let's see, Dawn mentioned that the oral drugs are free, but the patient's insurance can be charged as a dispensing fee. Thank you both so much for those comments. Dr. Rexford, I saw your question in there. She said, as I read the NIH and other guidelines, steroids are not indicated for outpatients, yet we see a lot of people coming out of the ER with steroids and azithromycin. So could you give an opinion about all of that? So I'll just throw that out there. Anyone with comments or a response to that would be wonderful.
From an antimicrobial stewardship perspective, that is the area I traditionally practice in. Azithromycin specifically for COVID-19, while that was a recommendation, a thought that it could be a potential therapy in the beginning of the pandemic, that's really been ruled out at this point. Azithromycin doesn't possess any activity really or clinical efficacy. A lot of times with the azithromycin prescriptions, there may be a concern for a concomitant bacterial pneumonia in some of these patients. That has actually been shown to be pretty low. There's been studies that have come out that have shown that in patients that are admitted to the hospital with COVID-19, around less, I think the the percentage is less than 5% of those patients actually have a concomitant bacterial pneumonia. So, but if there's concern for that, the azithromycin could be a correct therapy for that. As far as steroids go, I think that's a little bit of a mixed picture. Really, if patients aren't requiring oxygen for oral steroids, we really wouldn't be using those. But with the limited bed availability, there might be some people that are getting sent home for at-home care that really maybe qualify for inpatient admission. But that's a little bit of a mixed picture. So I'll just comment on the azithromycin.
Thank you so much for answering that question. Dr. Costello, I noticed you.
Sure, the only thing I would add is that, I think other countries do other things. European countries also authorize the use of AstraZeneca, which has been one of the predominant vaccines given in the UK, and we did not. So I think, take it with a grain of salt. This is the challenge that we all face in regards to, going off of what our FDA. So as a state perspective, that's what we would follow, the FDA and CDC, based upon, the US standards. But certainly, I think what we've seen throughout the pandemic is that different countries take different approaches, and is why we'll be studying this pandemic for years to come. So I think, it'll be ongoing, interesting to see how these get used. I would say, just in large, I don't think we're seeing as much as what we thought use of the oral antivirals initially were going to happen, but I think over time we'll probably see that pick up, and hopefully the supply will pick up. But I can't remember if Contessa hit it on this or not. It takes a really long time to make a course of Paxlovid, like 9 months. They're trying to work on that timing, but that's part of the challenge with these. At one point we had a big supply of monoclonals, and then we certainly have seen that get depleted. And as Contessa mentioned, the effectiveness of some of those. So it's going to continue to be an ongoing challenge and a balance of, when should we really be using these therapies, and, based upon the supply that we have available to try to prevent that severe disease.
Thank you so much. And Dr. Valtierra, I noticed you also chatted in saying that there may be a role for inhaled steroids as well. So thank you for adding that. We did have another question come in asking, do you have any information on the cost of these treatments?
So as far as the cost goes, Paxlovid, molnupiravir, and sotrovimab are government purchased products. So I don't have any of the costs at this moment. The cost to the patient, I think someone put there could be a dispensing fee for the patient for the oral therapies. I'm not exactly sure on that, but that could be a thought. But the drug themselves are free to the patient as they are government purchased. And then Dr. Costello was explaining they get distributed out by the state. Sotrovimab is also government purchased. There may be an infusion fee required with that, depending on the facility. But the drug itself is purchased by the government.
Yeah, and the only thing I would add in, because I was really glad Contessa talked about remdesivir. I think sometimes we forget about remdesivir because it was, all the way of people I've frequently been, that was back in 2020. So, we're really like throwing it back. But my understanding is just this week or last week, there were codes provided for even outpatient administration of remdesivir for billing purposes, because as I said, since that's now on a fully approved product, it has to be purchased through traditional means to purchase therapeutics, not like the other oral antivirals right now, or the monoclonals, which are still federally distributed. So there is some work to try to defray the cost of that. But I think remembering that remdesivir is also a treatment option. And now there are some places looking at being able to administer that even in an outpatient setting, and having compensation for that. I think that was some of the concern with the remdesivir outpatient, that it would be a bigger cost to the patient. And so I think that's why some places have been hesitant to do that. But my understanding is, I think they're working on better payment codes for that so that it's not as much burden to the patient. And I think the dispensing fee is very limited. It's a low cost, and I am under the impression for the oral antivirals, it's also covered, and same thing for the antibodies. There can be an infusion fee charged for administration of that, so an administration fee by the hospital. But just like with vaccines, the product itself is free. It's just, billing for the actual administration of it.
Thank you so much for adding that, Dr. Costello. No new questions in the chat, so we can also go into open forum. If anyone has anything that they want to add, feel free to unmute. You don't have to just chat in. You're welcome to unmute and ask away as well.
Yeah, Mithra, this is David Baltiera. I don't know if people have actually had the opportunity to prescribe Paxlovid. It's not horrible, but you do have to contact the pharmacy, get the forms filled out, send them the prescription, send them the positive test. And so it does take some work. And so the first time you do it, it's not going to be easy, but it's not overly burdensome either. And, from my experience, the website is pretty accurate. The pharmacists have been very willing to work with that. And so it shouldn't be a big burden except for availability. So our local pharmacy for 2 counties had 20 doses for, several weeks. And so it goes down to 12, goes down to 8. But they weren't being overly used. So I would encourage people definitely for your higher risk patients to use it and contact your pharmacy and they'll work you through it. So just kind of an experience on using it actually.
And no, thank you so much for sharing your experience with that and sharing that with the group.
Yeah, and just to chime in, you're exactly right. The initial 14 locations in West Virginia, it was a limited supply. That's why we put in the process of contacting the pharmacy first, because if a bunch of people were prescribing it, you could have a person show up and they don't have the medication available. So it certainly isn't ideal, and we get that there's extra steps. It was just, we were trying to prevent a long line at a pharmacy and then people being irate because there wasn't product available. Hopefully, as supply increases, and we already got a little bit of an increase, I'm not talking anything major, I'm talking like 80 extra doses. The state is looking at how to further, based upon use and positivity rate, have additional doses in certain locations to meet the need. But I think that's really good feedback in regards to, I think once you do it a couple times, it gets a little easier. But, at this time, a physician, a nurse practitioner, or a PA are the prescribers through the EUA to give the med. So hopefully this will improve over time, but it's just kind of where we're at right now with such a limited supply. I will just also add that moving forward, some community health centers are supposed to be getting a federal supply in addition to what the state supply is. So hopefully there will be some additional product coming to West Virginia that will increase our overall supply.
Yeah, that would be wonderful. Thank you. Any other comments, thoughts from the group, or experiences that you'd like to share with everyone? Alrighty, well, I'll give you all 15 minutes back to your day. Again, big thank you to Contessa Howard. I really appreciate you kind of on last notice to putting together a wonderful presentation and answering the questions and all that. So we really appreciate your time today.
Yeah, thank you guys so much. It's been a pleasure. Appreciate it. And in the COVID world, I live my life in last minute. So it's no big deal.
Well, it's very impressive, so thank you. And again, all the resources, PowerPoints, everything great that came through the chat, I'll make sure are included in the recap email. My only announcement is that our next session will be on February 17th. So we'll see you all next time, and thank you all so much. Take care.
Thank you.